My topic today is on Sentinel node, whether it has replaced full lymphadenectomy in gynecologic oncology or not. Just a brief overview. Going to start with the introduction and then just a brief historical background. Then I'll go according to the systems, organ systems. So lymphatic assessment in gynecology is one of the important components of staging. Traditionally, lymphadenectomy has been part of the gold standard to evaluate lymphatic metastasis. However, lymphadenectomy is associated with complications, and morbidity impairs quality of life in several domains, including social, psychological well-being, and activities of daily living. So what is Sentinel node? Sentinel actually refers to a guard or a bodyguard or something like that. So it's the first node that receives drainage from the primary tumor and therefore has the highest probability of containing metastatic disease. So in theory, if the node is negative of metastasis, then the remainder of the node in that basin should be negative. So the primary tumor, I don't have a pointer. Really, do you have a pointer? Maybe don't have a pointer. Okay, so the primary tumor will first drain to the sentinel node. In most of the time, it's one, but it can be more than one. Before it drains to the rest of the lymphatic channel. So it is not something new. In 1977, Cabanas had already pioneered sentinel node mapping in penile carcinoma using lymphoangiography. And he described it as the primary site of metastasis for penile carcinoma. And the following years, before the 80s, there were other studies using the radiocolloid, that's stagnazium, but with the introduction of methylene blue and other isosulfan blue, and they started using more of a combined technique. In the early 90s, that's when we had now mainly melanoma and breast cancer using sentinel node, but also later on vulva cancer. So as part of their management of cancers. So endometrial cancer, we know that it's the second most common gynecological cancer, even here with us. In the Western world, it's actually the first most common cancer. We know that it's associated with high BMI. Lymphatic metastasis occurs in about 10 to 15%. That is just in general, but we know that in early stage of cancer, it's much, much lower than that. Lymphatic mets is one of the most important factors predicting survival. In endometrial cancer, we usually do hysterectomy with bilateral sapping oophorectomy, but also lymphadenectomy has been part of the management. And however, lymphadenectomy is required for accurate staging, so it helps us to assign the accurate staging of that certain disease. But however, we have not been able to prove therapeutic benefit of this. So there are currently 2 randomized control studies that were done looking at therapeutic benefit of lymphadenectomy. They are both European. The first one was done by the Italians, where they looked at 514 patients in early stage endometrial cancer, assigning them for full lymphadenectomy versus no lymphadenectomy. And what they found was that in the lymphadenectomy arm, they were able to, 10% of those patients were able to have their stage. So from stage 1, they were able to go to stage 3. However, they did not, there was no improvement in overall survival or disease-free survival, but there were more complications in the lymphadenectomy arm. So the follow-up study was the Aztec study with more 1,408 patients looking at stage 1 and stage 2 endometrial cancers. It was a multi-center study with 4 countries involved. The main aim is just to look at survival, and their result was also the same as the Aztec trial. So no improvement in the overall survival. So we have now lymphadenectomy with high morbidity, and we were not able to prove therapeutic benefit of this procedure. What is the risk of metastasis? In early stage cancer is actually relatively low. If we look at the Mayo Clinic study that was done in 2000 using the GOG 33 criteria of endometrial cancer of grade 1 and grade 2 with a tumor size that was less than 2 centimeters and myometrial invasion of less than 50%, they found less than 5% nodal metastasis. So that's quite low. There have been other prospective studies looking at the risk of nodal metastasis, and the follow-up study done by the same group from the Mayo Clinic actually found about 1% of nodal metastasis. So we're basically doing a lymphadenectomy, especially in early stage cancer for patients that have very, very low risk of getting nodal metastasis. So what are the morbidity associated with lymphadenectomy? Mainly is lymphedema, that's what we see mostly, but also lymphocyl, vascular injury, and nerve injury, increased blood loss, and also the fact that the pelvic side wall is full of big vessels and nerves, so we definitely are very careful doing lymphadenectomy in that area, so that definitely increases our operation time. There was a recent study done by the GOG22 group study. That's the leg study that I'll talk now. That was a prospective study looking at 1,054 women. All women went for surgery for cervical, endometrial, and vulva cancer. What they did is they measured the leg circumference starting from the bottom of the heel up to the inguinal crest, at 10 centimeters apart, and then they calculated the lymph volume change. Then they followed up this patient 6 weeks up to 24 months post-op. They defined lymphedema as a lymph volume change of more than 10% and the highest of more than 20%. So what they found is that lymphedema was, with lymph volume change of more than 10%, was actually 34% morbidity. So that's quite high. With the severe lymphedema, lymph volume change of 20%, it was actually 11%. So how do we do sentinel nodes? What are the techniques? The method that are described are the colorimetric method. That's the isosulfane blue and methylene blue. We know the methylene blue here. We do have it at the pharmacy. And then there's the radionuclear technique, the radiolabel colloid, that's the technetium-99, and then the near-infrared, which is now the new kid on the block, I'll say. So that's the indocyanide green. So it's very simple. When I have another slide somewhere where you can actually see the indocyanide green. But basically what you will see when you open up the patient is a node plus a lymphatic chain where it drains. Where do you inject the dye or whatever you want to inject? So you can inject it in the cervical or myometrial or hysteroscopic tumoral injection. What is recommended by the NCCN and everyone else is cervical injection, simply because it's easier to perform, but also it has a high detection rate and doesn't require a lot of time. What they recommend is to inject at 9 and 3, which is easy, but you can also inject at other sites that are shown there. So what is the detection rate of this? I'm really sorry, this slide is very busy and very small. But what it's showing is actually what are the detection rate of this, and I've actually zoomed the indocyanide green, looking at the studies that have been done, and you see that if you sum up that the detection rate is about 95%. And the one in bracket is the bilateral. Bilateral is usually less, and para-aortic is about 12.7%. What is also described is that we usually use a combine, so where we give technetium with either methylene blue or with indocyanate green. And the combined technique with indocyanate green is actually also has a high detection rate. There is a randomized trial study that was released last year by Frumovitz looking at comparing ICG with ISB. 180 patients enrolled, and what they found is an average 3.1 sentinel node identified per patient. At least there was one sentinel node identified in 96% of the women in the ISG arm versus 74% in the ISB arm. Bilateral mapping was quite high with the ISG compared to the ISB. And there was 8.5% lymph node metastasis, and they were all detected with the indocyanate green. So what they concluded here was that ICG should become the standard dye for sentinel node in endometrial cancer. There were also other studies, the FIRES trial looking at 308 women. This was more to do with sensitivity rather than detection. Looking at early stage endometrial cancer with all histologies, but there was also 26% of high-grade endometrial cancer. The dye that they used was the ISG. ISG was removed, and then they assessed it, and then they continued the full lymphadenectomy. So the sensitivity of mapping was 97.2%, and negative predictive value of 99.6. So that's quite good. And more than half of the nodal mets were detected with ultra staging. So once the node is removed, it needs to be assessed. Initially, intra-op, the node will be removed, and frozen section should be done to check whether there is metastasis or not. However, frozen section has been shown to have some. Sorry. Apologies. Okay. So the issue with frozen section is that it's good in a center where they've used it many times and they have a good, reliable lab which can give them a reliable answer. But in a center where you have not used it many times, you might end up with false negative or false positive result. So routinely, the node will be cut into 2 millimeter sections and all halved, and then it will be embedded on a paraffin slide and stained with hematoxylin and arsine, and then evaluated to look whether there's any nodes, mets that they can see. If there's any foci of metastasis they can see, then they can proceed with ultra staging. Ultra staging basically means deep sections, very small sections of that node. What the SGO described is taking both and cutting into 50 micrometers intervals, and 5 micrometer sections and 50 micrometer intervals. And then you stain it still with the H&E and also cytokeratin. So unfortunately, in endometrial cancer, we don't have good or studies looking at the pathological review on ultra staging. So what we are using now is what is from the breast cancer. That is now what was adopted by the SGO and the AJCC. So micrometastasis will be a tumor that is more than 2 millimeter, and then the micro will be the one that is more than 0.2, but not more than 2. And then but of course you can get those very, very just isolated, what we call isolated tumor cells. So with lymph node, with ultra staging, you will pick up early stage of cancer with ultra staging, which will not be able to pick up with just normal stains. Of course, there is a bit of discussion, and I would not say controversy, about the value of micrometastasis compared to macrometastasis. And there is now data showing that with micrometastasis, the progression-free survival is longer compared to macrometastasis. If you look at micro and isolated tumor cells, there's really no strong data to prove that overall survival or whatever survival is longer. So nowadays we are kind of like clustering them in one group. So if we can take, for example, Holloway, a study that was done in 2016, where he looked at 119 sentinel nodes, 12% of those were they diagnosed cancer with macrometastasis, and 8.4 of those they diagnosed with micrometastasis, and there was still 10% that they found with just isolated tumor cells only. What the NCCN recommend now is when you are doing the sentinel node mapping, you should be using algorithm. This is so that you are able to reduce false negative rate. When you don't, they've shown that if you don't use algorithm, your rate is high, but if you use it, you are able to reduce it to much, much lower. So it basically guides you what you should do when you're inside there. If you are able to see the node, you should take it out. But if you are able to see bulky nodes, even though you found the sentinel node, you should be able to remove the bulky nodes. And where you are not able to find any sentinel node, you should continue with the full lymphadenectomy. So when it comes to mapping, you should be guided by the algorithm. So we'll move now to cervical cancer. Cervical cancer is the most common cancer here in our country. Lymph node status is one of the most predictor of treatment. Predicting treatment and survival, especially in early stage and also in advanced stage. The standard of treatment for early stage cervical cancer is radical hysterectomy with pelvic and parotid lymph nodes. However, just like in endometrial cancer, the risk of lymph node metastasis is low. With 1B, it's a bit higher, but up to 1A2, it's actually 3.2%. And with the GeoG22 that I said on the previous slide, the morbidity is actually 34%. So mapping techniques, it is the same as in endometrial cancer, where you use either ICG or whatever you have, the blue dye and the technetium. The same with endometrial cancer, they recommend that you have to use an algorithm system. However, with cervical cancer compared to endometrial cancer, with cervical cancer, the tumor is confined to the cervix, so they do not recommend that you inject where the tumor is, because that will definitely affect the drainage of your dye into the lymphatic system, so you have to inject peripherally. Okay. So what evidence do we have with cervical cancer? Sorry. Good. Okay, so BVs looked at 30 early stage cervical cancer up to 1B1, of which actually the majority of them were 1B1, and he used the dye, ICG as his mapping dye, followed by radical hysterectomy and node dissection. And they found actually good results, 100% detection rate with ICG unilateral and 87% detection rate with bilateral. There were always stories, there were always controversy about tumor size that were more than 2 centimeters, whether you are able to have a good detection rate, but in his study he found that the tumor size did not affect the mapping technique. This is the result of his study. You can see that the tumor size of more than 2 centimeters was 94.1%. And most of the sentinel nodes were picked up on the hypogastric vessels, but also on the obturate and external iliac. They could pick up some of those. Very few were picked up in the paraortics. There were other previous studies done. The French did the SENTICOL Trial. This is the Lecourou and the group. It was a prospective study assessing the sensitivity and the negative predictive value of the sentinel biopsy up to CA cervix stage 1B1. They used the technetium 99 with patent blue. And they found a detection rate of 97.8% with a sensitivity of 92 and a negative predictive value of 98%. There was a follow-up study looking at overall survival and progression and recurrence-free survival and morbidity, the SENTICOL 2 by the same group. It was this time around, it was a randomized multi-center study. A patient underwent sentinel mapping followed by randomization to full lymphadenectomy, to just further lymphadenectomy, no dissection or not. So the group was CA cervix 1A up to 2A1, and what they found was an overall and 3-year recurrent survival free of 92 in the sentinel node only compared to the full node dilatation, node dissection of 95%. That's the overall survival, and 98% versus 99% for the 3-year survival. However, lymphedema and surgical and neurological morbidity was significantly lower in the sentinel node arm. So it just proves that you still have a good sensitivity, good detection rate and sensitivity with a high negative predictive value, but still have significant morbidity when you do lymphadenectomy in the cervical cancer. Okay, what about vulvar cancer? Most of the sentinel nodes were done in the vulvar cancer. I think it's still being practiced simply because the morbidities here, apart from lymphedema, we have wound breakdown, cellulitis, and these are quite significant. I think recently we had 2 patients who had, wound sepsis. One had to end up with wound debridement, and they all stayed in the hospital for quite some time. So vulvar cancer is not that, it's about 4 to 5% in developed country. The difference compared to cervical and endometrial is here, a positive lymph node affects survival much higher. It's with a 75% mortality rate. And also with early stage cancer, you still have a higher risk of nodal metastasis compared to cervical and endometrial. However, the risk of morbidity is also very high. I think in the GOG 244, we got 45%. It's for lymphedema, so it goes up to 70%. Some have got it up to 70% of lymphedema. There are 2 big studies on vulvar cancer. The Groins V, this is the Dutch study looking at multi-center observational study. There were 15 centers looking at the safety and the clinical utility of sentinel node procedure in early stage cancer. So they took stage 1 and stage 2 squamous cell carcinoma tumor that were unifocal, less than 4 centimeters with a depth of invasion of 1 millimeter, and there were no clinically palpable nodes. They looked at 406 patients. Of those, if you combine the nodes that they sampled, there were 623 nodes. 259 of those were unifocal disease with a negative sentinel node and a median follow-up of 35 months. So their primary objective was to look at recurrence of growing recurrence, and they found 6 growing recurrence, which came up to 2.3% with a 3-year survival rate of 97%. However, they also looked at the morbidity associated of these patients. They grouped them into short-term and long-term morbidity. The short-term was cellulitis and wound break time, and they were 11% and 4.5% respectively. I mean 11% for sentinel nodes and 34 patients for the full lymph node dissection, and cellulitis 4.5 versus 21.3. The long-term was mainly lymphedema and recurrent erysipelas. And lymphedema, you can see that in the full lymphadenectomy, it was 25.2%. It's quite high. There was a follow-up study by the GOG 173. This was a multi-institutional also with more centers, 47 centers, looking at 452 women in early stage cancer. They increased their primary tumor diameter up to 6 centimeters, but had still more than 1 millimeter of depth of invasion. So all patients had sentinel node plus full node dissection, looking at false negative predictive value for sentinel node biopsy. And they found it to be around 3.7%, And false negative rate for the tumor up to 4% was actually 2%, but it was much higher if it was more than 6%. And the sensitivity was also quite good, 91.7 with a negative predictive value of 96.7. So what was the recommendation in this study? That a sentinel node in vulva must be performed on unifocal disease, ideally for patients who are a tumor that is less than 4 centimeters and no history of vulvar surgery, because that distorts your lymphatic drainage. And the combined technique is what was recommended, but also the skills of the surgeon must be in performing sentinel node the surgeon must be adequately trained and must have the skill to perform sentinel nodes. So to conclude, sentinel node mapping can be offered in early stage cancer of the disease, however controversy when it's advanced stage or upper stage. The surgeon must be trained on performing sentinel node because that reduces your false negative rate, and you should be using algorithm when performing this, and you should have a good pathology that is able to give you a good frozen section and ultra staging. Thank you. It's fine.
Okay, thank you. I just have a question about this agents that you guys inject, the dye. I think you spoke about ICG and then there's lethal and blue. So I've never done this before, so I'm asking. I just want to know, is there any controversy regarding these agents being cytotoxic to the lymphatic vessels or increasing spread or something when you are basically injecting this into the vascular structures?
With the blue dye, there's two groups. There's the isosulfan blue and methylene blue. Isosulfan blue has been associated with allergic reaction, I think, and anaphylactic reaction. They quote it at around, I think, 1% when you inject it. So you should be able, in a patient who has had previous reaction of methylene blue or something like that, you should be cautious, or you should be able to give them steroid or something. The criteria is very important. You inject it in the cervix at 3 and 9 on the stroma of the cervix, not very deep, and the volume is depending on what you use. I think the blue is up to, isosulfan blue is up to 6 millimeter, while the methylene blue is up to 4 millimeter. There's no described adverse effect on the lymph node itself. The technetium, it's done pre-operatively, so it's done ideally the day before, because it's a radioactive material that has to decay in the body, but it's still safe. It stays up to 24 hours into the body of the patient. So she goes to nuclear medicine. Then you inject it. It's very, very small doses that you inject, and then she gets a lymphocytogram or a SPECT CT so that you can get a 3D location of that. You can also mark it so that you know for the groin, you can mark how deep it is and where anterior it is. And with your SPECT CT pictures, you can also guide you. Of course, radioactive material, there's always safety issues involved. You have to have gloves on. You have to give the right dose, and once you're done with that, you have to put it in a specific lead protecting area, but it is safe for the patient. Indocyanate green, there is also a bit of an allergic and anaphylactic reaction, but it's quite low compared to isosulfan blue. It's not Bonnie's blue that we use in theater. No, it's completely different. So if what we have used is the combined technique with the vulvar cancer, we've had now four or three cases since last year. So with the combined technique, if you inject the patient with technetium, you need to have a gamma probe that you have to use. So you can get that from nuclear medicine. It's quite a small probe. It's almost the size of the microphone. But with the blue dye, you are able to basically look at the lymphatic channel. It will be blue, and you're able to see the blue node, which is the node, sentinel node. Okay. So.
It sounds easier than it is. I think the blue takes a bit of digging to try and actually find it. It's not like you open the groin and there's the blue node. You actually have to dissect out and see if you can find it. So the radioactive is helpful in locating where exactly you're going to dissect.
The nose are in any case dispersed in.
Yeah.
So, which is a little bit different.
So
when you do the pelvic nose, because they run along the blood vessels, so you follow the blood vessels. But for that you need a very specific light for the ICG that you plant. So that green you only see when you switch on that light. You can't see it with the natural light.
So the uterus is a central organ, and if you have cervix or endometrial CA, what do you do if you only locate a unilateral sentinel node and the other side doesn't show up?
That's a very important question.
Where's my algorithm?
I saw your percentages for.
So if you locate one side, then you have to perform a lymphadenectomy on that side. That way when you don't find a sentinel node on that, whether there's unilateral or bilateral, you have to do lymphadenectomy on the side.
What's been shown is that sometimes you won't find a sentinel node on a side because the sentinel node has been totally displaced by tumor, and then it doesn't show up on the sentinel node. So that's the sort of safety mechanism in it. If you can't identify a sentinel